Thank you, Travis, very much. Kojo and Travis, would you please go to the table? We are running, as you know, we started 10 minutes late. So we do have 15 minutes for discussion. If you have any questions for either Kojo, Travis, or myself, please go to the microphone. And for those online, please put your questions in the chat box.
Good morning.
You should actually introduce yourself. I forgot that.
Good morning.
We know who you are.
Absolutely. My name is Mia Levy. I'm the Chief Medical Officer at Foundation Medicine. It was fabulous to see you all and give us a great opening to today's meeting. I have two questions. The first one is for Travis. I was thinking back on that genomics module implementation that you were referring to, and thinking how it took almost a decade for that committee to actually agree on the standard and first version of the standard that could be implemented. These standards bodies are basically volunteer organizations. We get together and we try to get consensus on what a standard should look like for a particular set of data. What could be done to accelerate that process, and how are you thinking of that in terms of M-code at this point?
Yeah, thanks, Dr. Levy. It's a fantastic question. I think one of the things that sets M-code apart is that we've always purposely kept the M lowercase, really to emphasize the minimal nature. We started with 2 use cases and fully acknowledged that it was not going to cover the entire space. And that's different than, I think, the HL7 approach, where if you are going to propose the standard for the clinical genomics transmission of data, you really do have to consider all use cases from the beginning. And I think that's a much slower process. So we took a pragmatic approach and said to implementers, we acknowledge that this isn't going to cover everyone's needs from the beginning, but let's set up a governance process where we can have rapid feedback from the implementers. We can set up a group in our group, we call it the technology review group. They can take that feedback and then we can rapidly integrate on that model. It's similar to a PDSA cycle like we would all do at our institutions. And I think that pragmatic approach has actually worked really well for us. And some of that is really the cooperation we've had with MITRE and the Codex group that does all the implementations or manages the group that brings the implementers together. And so I think that that's probably the biggest piece is you can try to have full scope from the beginning, or you can set up a system to rapidly integrate and rapidly evolve your model over time. We chose to do the latter.
And maybe I could ask a follow-on question to that. So if I'm understanding sort of the difference between a HL7 standard being, really, really complete, I think our vendor who implemented that HL7 standard, they wanted to wait to implement it until the dust had settled on the standard, and that delayed the process by probably 5 or 6 years. Versus M-code, how are you finding the vendors willing to implement an early standard in that regard?
Yeah, so this was actually, I think, one of the big accomplishments for 2022. So we chose to abide by the FHIR maturity model, which gives vendors a labeling system for each of the 6 domains within M-code that labels the maturity. And then we make a commitment, if you're at level 4 and above, that we will not make an incompatible change, a backward breaking change to the data standard without consulting implementers. So we actually just presented the committee of practice, the group of people that are implementing M-code in January with a list of proposed changes for standard for trial use 3. I think 2 or 3 of those were backward changes that would break current installations to get feedback. And so it really turns a lot of those decisions over to the community that are actually using it. And so we would not be a data standard without working very closely with implementers that are using it.
All right, and my second set of questions, I apologize for taking so much time for the other 2 presenters. You mentioned the challenges of imaging in being able to get annotations on the images themselves with respect to be able to apply machine learning algorithms. And then Travis mentioned workflow as really the biggest hurdle in any of these implementations. Where are you seeing the opportunities in the workflow for image-based diagnostics, both pathology and image and radiology, to be able to break this challenge of image annotation itself?
So I'll try to answer that, but I know we have a computer expert in the audience, Mia. I can tell you that we have 3 integrated diagnostics projects at MSK: neuroendocrine tumor, brain tumors, and lymphoma. And they basically ask me to emphasize over and over, the progress is very slow, painfully slow, to annotate, because integrated diagnostics requires large data sets. You do have annotation and segmentation on 100 patients, but our people are annotating 2,000 patients. And to really segment each lesion, I don't have to tell you how long. And it's really developing together with the computer experts and industry, the AI that is also validated. AI that's not only going to segment an obvious lesion that's nice and round or maybe a little speculated, but segment lesions in all parts of the body. So we so badly need AI segmentation, extraction, feature extractions, and classifications. If you look in the literature, you would think we are there. There are papers every week celebrating yet another success. But when you are on the ground level working on the cases, it's just not so.
So
It's really collaboration, and it's really getting, but they have to, when AI, those algorithms are developed, they need to be sitting next to, in radiology, next to the expert. Otherwise, it just won't, I don't think it will work. We had example of different specialties segmenting lung lesions. When we looked back, they were segmenting atelectasis, they were segmented normal granulomas. So it really requires tremendous amount of work. It's collaboration. And money from, they have people. We don't have, industry has people. And together, I think we can do it. What do you think? It's your area of expertise.
Well, I think Kojo might have a comment, and then I'll say something else.
Thanks, Mia. It's a great question. I think there are infrastructural issues that belie the reason why there's non-standard ways of acquiring this data. The first thing is that it's currently manual. The second thing that I think is very important is that where in our healthcare delivery system is there accounting for the effort that delivers the expertise to appropriately capture this data? Who's paying for that work? And there is no mechanism. This is infrastructural. So that's what the problem is. So maybe someday somebody gets access to some little philanthropy, or one person gets some access to some funding that's supposed to deal with a particular project, and then they go and prevail on their friends in pathology or radiology to, this is a great opportunity, and we keep approaching the problem in a patchwork fashion because there is no system to do this in a standardized way. And then the other thing that I think is also problematic is that there are no standards because we've never learned to do this in a systematic way. So somebody could image atelectasis thinking that, well, that's good enough because you're just using an individual who's just been adapted for that project because there are no standards. So I think it's the infrastructural issues that have to be addressed. And somewhere in our healthcare delivery system, we have to account for the individuals who are going to do that work. Before we get to the point where we've acquired the information that can actually be used to train all of the sophisticated AI programs. And that has to be done at scale because, if I do 5, you might as well not do it at all.
I fully see that as one of the major challenges right now in image-based AI. We have tons and tons and tons of images. I mean, so much data in images, none of it is annotated for the images themselves. And we just simply don't have workflows that, I mean, when I look at through my radiology reports and they say, you know, image series 5, image 123, and I can go look at that and there's an X marks the spot. I'm like, thank you for marking the X, you know, that you wanted to bring to my attention. But there's no annotation behind those regions of interest that someone has bothered to put there, and there is no incentive alignment to change that. And if anything, we'd be creating a new incentive that then the radiologists won't want to get rid of because they'll get some additional funded, you know, reimbursement for that activity, only for it to be replaced by AI in the future. So it is a bit of a catch-22 to think about how we're going to even do the effort of getting all these images annotated so that the wonderful AI developers in this community can actually produce something useful for us. So thank you.
So Mia, I think we have representatives here from the industry that are really working on segmentation in AI, but you're absolutely right. As long as we're segmenting manually, it's a bottleneck. It takes really a long, long time. Larry?
Larry?
Yes, Larry Schulman from the University of Pennsylvania. Terrific talks, and but I'm a clinician, so I had a clinical thought to share with you. I mean, Hedy, you talked a lot about the varying degrees of certainty about assessing a patient's status when imaging, and on the bottom of one of your slides in little print, you had patient-reported outcomes. And Travis also mentioned clinical evaluation of the status of the patient, and acknowledging the fact that neither of those factors, either patient-reported outcomes or the clinician's overall patient assessment, are often in structured data, although some of us are trying to change that. I would just make a plea to include those factors in part of your integrated diagnostics.
Yes, Larry, thank you. We introduced a lexicon in 2009, and today 96% compliance is above 96%. But introducing lexicon in radiology community, and we have here 2 leaders, it's extremely painful, but it has to, just like you said, top down. Second, clinical data are essential part of integrated diagnostics. I didn't talk about that because it's for the clinician to talk about that, but we have Saurabh is behind you. We actually contracted with a company in India to convert those clinical data in the structured digital format. But there is a problem if the clinical notes don't have any certainty in them. How do you guess? So we have, Larry, challenges are humongous, but doesn't mean that we should give up.
So I completely agree, and I think we do have the opportunity, just like you're working hard to do this in radiology or genomics or other areas where you're trying to structure data that can truly be used in lots of different ways. We need to figure out how to incentivize the clinicians to do the same thing. And I think there are ways that we can do with longer conversation. So thank you.
So Larry, we incentivized in our department. We said, do it. And that's what he did the same. And that's what they did. Just, it has to, certain things in life have to come top down.
Yep.
Your example as well.
Yep.
Saurabh.
Thank you.
Quick question.
Good morning. Thanks for the lovely talks. Saurabh Shah from Memorial Sloan Kettering. So I wanted to also comment on the annotation, the manual annotation. So it's very important to have accuracy, but it's also very important to have a large volume of data. And it seems like manual, precise segmentation, thorough segmentation is completely unscalable to the volume that's needed to actually train the models. the success of ChatGPT, for example, is really just due to being able to encode the internet, if you will, and throw billions of dollars of GPUs to train these very sophisticated semantic models that can do long-range interaction. So where I'm getting at is how do we navigate this highly accurate small data sets? Even if it's 2,000, it's not enough. It's probably need three more zeros on that, I think, to get enough. Versus, let's say, semi-automated or less accurate per patient, but large volumes that could be used to train models. And there, I would like the panel to perhaps comment on the ability to capture the actions of the radiologist or pathologist as they're doing their work, so that in a completely automated system, without the clinicians having to change their workflow, we can capture the actions, and potentially maybe that's a route towards this scalability.
Thanks. I think I'll take that very briefly so we can transition and we can talk offline a little bit. I think the key thing is the alignment of the incentives. And the way things are currently structured, the pathologists I can speak for are incentivized to produce a certain kind of product, and there's a yield that is understood from that kind of work product. Nothing out of all of this requires them to be able, as humans, to be annotate at scale. Somehow we have to re-engineer the system to, at scale, be able to capture this information in a manner in which we can actually use it to improve on a serial basis. If we're doing things the way we're doing them now, it's just not going to work. And I think the incentives have to be aligned. And other than that, you'll have to, we'll be spinning our wheels.
So I think that your question perhaps would be better answered by Dorin. Maybe in your talk, you can specifically mention, because there are people that are already doing. It's not from ChatGPT. They are really doing unsupervised training. And actually, there's an excellent paper in Nature Review showing recently, and I'll be happy to send to you, exactly the difference between closely monitored and supervised annotations and really automated or unsupervised, and I know some of our speakers are doing that, so they'll answer your question. With this in mind, it's our, not lunchtime yet, break, coffee break. Please enjoy coffee break, and we'll be ready for the next session, monitored by Kojo and Nancy. Is Nancy here? Oh, virtual, okay.